outline today, since we're discussing on anxiety and insomnia, we'll start with the introduction, then next the definition, etiology of causes, epidemiology, the pathophysiology, the DSM-V, which is the Diagnosis and Statistical Manual of Mental Disorders, and the International Classification of Diseases classification for anxiety. We'll discuss the types of anxiety disorders we have, clinical presentation, management, and our screening tools, and then a case study for everyone at the end of this webinar. And for the insomnia, we'll talk about definition, stages of sleep, etiology, epidemiology, the pathophysiology, the types of insomnia we have, DSM-V criteria, management, complications, and a post-test also after this. Then next is our introduction.
Okay, so welcome back once more. I hope today's presentation would be as simplified as possible and applicable as possible so that we can actually apply it to our day-to-day care of patients. So by way of introduction, anxiety and fear has been used interchangeably. However, fear is an automated neuropsychological state of alarm that is characterized by a flight or fight response to that awareness of either a real or perceived threat or danger. Anxiety is actually linked to threats, but is more like a future-oriented mood state that has to do with a complex mix of several factors from the affective, physiological, behavioral response to a perceived threat, whether it's real or not. But there's this response that usually occurs in anxiety. It becomes pathological when this effect is overestimated erroneously, leading to excessive and inappropriate responses. Insomnia, on the other hand, is characterized by persistent difficulty with sleep initiation, meaning that you go to bed, you're tossing and turning, and cannot initiate sleep. Maintenance or quality refreshing sleep, despite adequate opportunities for sleep. So it's not like you're on call at work or you're jet lagged. You have every opportunity to sleep, but still sleep would not come. This can lead to daytime consequences and nighttime effects. Insomnia is a highly preventable problem that results in increased use of healthcare services and functional impairments. I'm sure that you've come across several patients or guests, like we refer to them in cardio care, that always reports, "Doctor, I can't sleep.
Yes.
I did not sleep well last night." Common to almost every guest that we've come across. It can be acute or chronic insomnia by way of a classification based on etiology.
All right, so next we're talking about the anxiety disorder. So we have a pre-test for us to answer. So you don't need to, it doesn't necessarily need to be right or wrong.
It's just a way of, making sure we have an idea.
Yes.
And then by the end, something's not clear would be made clear.
Exactly. So the first one is, which of the following is the first-line medication for generalized anxiety disorder? A is buspirone, B is tricyclic antidepressants, C is SSRI, so selective serotonin reuptake inhibitors, and D is benzodiazepines.
Okay, so you can post your answer in the chat box. They would do the corrections at the end of this presentation.
Yes.
Go to the next one.
And the next question is the main neurotransmitter implicated in the pathophysiology of anxiety disorders. So either dopamine, noradrenaline, serotonin, or GABA, which is your, yes.
Yeah.
Yes. And then the third one is, what is the definition of agoraphobia? Is it the fear of social situations? Is it the fear of contamination, fear of specific objects and animals, or the fear of leaving home or being in places where escape may be difficult?
Yes, so let us know what you think the answer that best defines agoraphobia is. Then the next question.
Last is the most effective non-pharmacological management for anxiety disorders. Do the guests need counseling, psychoanalysis done, or cognitive behavioral therapy, or hypnotherapy, which is hypnosis? So please just put your answers down in the chat box, please.
Okay, so So right now we'll focus on anxiety disorders. We'll talk about anxiety disorders first, and then next we'll delve a bit into insomnia. These are very two broad topics brought together. So we'll try to be concise and also straight to the point. Please feel free to post your answers on the chat on the chat box, please. Thank you. Okay, so anxiety disorders, like I said earlier, they're a group of mental disorders characterized by significant fear and anxiety. It leads to a lot of social, occupational, and personal functional impairments. Social, you mistake it for being shy, but they're actually anxious in social situations, hanging out, socializing, being out there, in a crowd where they could be judged either negatively or otherwise. Then occupational impairments, poor productivity at work, from presenteeism, you're at work but you're not productive, or absenteeism, missing work because of one issue or the other, and then personal functional impairment as well. Globally, they are considered the second most common type of mental disorders after depressive disorders. Fear and anxiety are often interchangeably linked, but clinically they actually differ. Fear is more like an emotional and physiological response to recognized threat. You see a car coming, you want to cross the road. What do? Will you stand there?
Not if
Oh, good. So you just run. And then anxiety, on the other hand, is clinically defined as an unpleasant emotional state for which the cause is either not readily identified or perceived to be uncontrollable or unavoidable. Like I said, it's a future oriented mood state. It may not be at the time, but you're anticipating that something wrong is about to happen. Okay. Etiology, there are different factors that could contribute to anxiety disorders. One of them is the genetic factors. Genetic factors, there are several factors under this, contributory factors under genetics. One is twin studies. Several twin studies have been carried out on anxiety disorder, even depression as well. But since we are focusing on anxiety disorder today, it's been shown that there is high heritability and higher concordance in monozygotic twins, that's identical twins, unlike dizygotic or unidentical twins. Heritability is as high as 55%. Also, family studies, first-degree relatives of people who are prone to to have anxiety disorders also are more likely, 2 to 6 times actually more likely to develop anxiety disorder. There's other several factors like neurotransmitter dysregulation. The major neurotransmitters, like the MCQ showed, from GABA to serotonin, norepinephrine, dopamine, and all. When they're dysregulated, it affects mood regulation, the way the brain interprets fear and anxiety, and that becomes pathologic. Medications. Some medications like, which medications would you think would cause, like corticosteroids? You also have beta, what's it called? Bronchodilators are some of the medications, phenytoin, that can actually precipitate anxiety disorders, and some herbal medications. Now, an important one is this environmental factors, adverse childhood experiences, children that experience neglect, children that experience abuse, physical or sexual abuse, children that grew up in families that are dysfunctional with lots of chaos, and or even traumatized in childhood would be prone to develop anxiety disorder. And then substance use, like which substances? Like
it's alcohol, if you're smoking, also cocaine, reading, or
Okay, so those are the etiological factors that we should be aware of.
So for the epidemiology, anxiety disorders is one of the most commonest psychiatric disorders in the general population. Now, anxiety is something that almost everyone has. It is a natural and physiological response to most situations, be it if you have a presentation at work, if you have lab test result that needs to come out, if you have a chronic illness. So there are so many things in which we can be anxious of. It's just if it's persistent, excessive, and it's for unreasonable factors. So it occurs more frequently in females than males in approximately a 2-to-1 ratio. So the lifetime prevalence in Africa ranges from 5 to 7% to 15.8%, and was as high as 47% in the general population during the COVID-19 pandemic. So this was when we had COVID, there was social isolation, loneliness, people were worried about job losses, financial worries. So if you have a generalized anxiety disorder, you'll be more worried about all these things. Factors such as exposure to stress, violence, gender, and poorer health conditions can also influence the prevalence of generalized anxiety disorders.
Yes, that's correct. So just a brief pathophysiology of anxiety disorder. So we've already mentioned those major neurotransmitters that mediate anxiety symptoms in the brain: GABA, norepinephrine, dopamine, serotonin. These symptoms are actually mediated by the sympathetic nervous system. The amygdala, which is like the threat detector in the brain, is always alert, on the alert to pick up any threat, whether it's real or not. And limbic system plays crucial roles and are linked to the prefrontal cortex regions, which are more like the control panel. They have a calming effect on the amygdala to be able to interpret threats and detect threats in the way it's meant to be. Then abnormal activation of the prefrontal limbic system may be reversed when there is psychological and pharmacological interventions. It's also good to note that the amygdala is also a point for for cognitive behavioral therapy. It actually has a positive effect on the amygdala, thereby in the long run improving the symptoms of anxiety disorder. So this is just a summary of the pathogenesis of anxiety. The risk factors we mentioned: female gender, the hormonal factors, estrogen, progesterone, dysregulation can affect, or fluctuations rather, can affect neurotransmitters in the brain. All the biological clock of a woman, from menstruation to pregnancy, menopause, causes some changes as well in the neurotransmitters, and this can precipitate anxiety. Genetics, as I've mentioned, and then other biological theories which are still under investigation. So these factors, at the end of the day, will lead to predisposition to anxiety. You have imbalance or abnormal functioning of norepinephrine, that's the neurotransmitters, serotonin, and GABA. So it then affects the hippocampus and cingulate gyres, leading to them to abnormally process threats. The hippocampus, when under a lot of stress from the nervous system, eventually becomes shrunken, and this affects the way it modulates mood or interprets threats. So perceived threats from the environment goes to the hippocampus. Also, the prefrontal cortex, which I said earlier, has a calming effect on the amygdala, is meant to modulate or help the amygdala interpret these threats, becomes impaired. So you now see that the amygdala, which is like the threat detector, starts going kind of haywire. There is oversensitization and overinterpretation of threats or stimulus, and this will lead to activation of fear responses maladaptively. So activation of the hypothalamus, pituitary adrenal cortex axis leads to increased cortisol release. We also know that cortisol is a stress hormone, and it just elicits, chronic stress. Activation of the autonomic nervous system and adrenal medulla leads to increased epinephrine release, preparing the body for a flight and fight response. So these stress hormones interact with brain and body in various complicated mechanisms that will now lead to anxiety disorders. The ability of the hippocampus to also normally integrate environmental stimulus is further compromised because of the stimulation from the autonomic nervous system. Remember, I said that constant stimulation, releasing of epinephrine, cortisol, causes shrinkage eventually of the hippocampus because it's on chronic activation by distress hormones, and this ability of the hippocampus to normally integrate environmental stimuli, modulates fear as well, becomes impaired. At the end of the day, there's mood dysregulation, memory impairment. So it's just a vicious cycle. At the end of the day, the person is prone to developing anxiety disorder. So it's a complex mechanisms that is in play that eventually precipitates anxiety in a person. Okay, so we'll go to the classification of anxiety disorders.
All right, so we have specific anxiety disorders and other anxiety-related disorders. So under specific anxiety disorders, we have generalized anxiety disorder, which has been discussed right now. We have the panic disorder. We have specific phobias, so they have fears for a specific situation, place, animal, depends. We have social anxiety disorders, agoraphobia. We have separation anxiety disorders, selective mutism. And then for the other anxiety-related disorders, it can be due to substance or medication-induced anxiety disorders. It can be anxiety disorder due to another medical condition like hypothyroidism. It can be other specified anxiety disorder.
So for this presentation, because there's a lot to talk about, just keep it brief and just focus on the ones asterisk, that is the GAD, panic disorder, specific phobia, social anxiety disorder, and agoraphobia. Separation anxiety disorder basically means excessive worry, when one is being separated from an attachment figure. It might be a mother who is excessively anxious of her child, who is in boarding school. You're afraid of, is he going to die? You're afraid of him coming to harm. You're having nightmares of something bad happening. And sometimes it can be excessive and becomes really pathologic. Selective mutism is basically when there's consistent failure to speak in certain social situations, when they can actually speak in other situations, like speaking in social settings, but at home they speak. So that's the select where they want to actually interact. So this is also a maladaptive form of as a result of anxiety in a person. So, but we are focusing on the ones asterisk because of how vast this topic is.
So we have classification of anxiety disorders according to the International Classification of Diseases, the revised 11th edition. So it's classified, first is the generalized anxiety disorder. We have the agoraphobia, panic disorder, specific phobia, social anxiety disorder, separation anxiety disorder, selective mutism, which are the tools that were just explained by my chief. We have other specified anxiety or fear-related disorders. And the last is anxiety or fear-related disorder, which is unspecified.
So we'll talk about generalized anxiety disorder, GAD. So generalized anxiety disorder, in this type of anxiety disorder, persons usually present with excessive anxiety about ordinary day-to-day situations. They are called worriers. They worry about everything, and they even worry about their worry. So the anxiety is intrusive. It causes tremendous distress and functional impairment in various aspects. They worry about work, they worry about their family, children, spouse, they worry about school. Every aspect of life is really affected. There's a lifetime prevalence of 3.7% worldwide. It's often associated with physical symptoms like sleep disturbance, restlessness, muscle tension, chronic fatigue, GI symptoms, and even headaches. Factors associated with GAD are female gender, being single, being stressed out, lower household income, divorce, separation, and even low educational level. So we'll just pinpoint how you diagnose GAD, generalized anxiety disorder, using the DSM-5 criteria test revision. So for GAD, these are the criteria. One is there will be excessive anxiety and worry occurring more often than not, meaning more days than not, for at least 6 months, which means 6 months and above, about activities of, cutting across several aspects of life, such as work, school, family. The individual finds it difficult to control their worry. This is very important. It's a very important factor. They cannot control the worry. As GAD is more like a continuous kind of anxiety disorder, with varying intensity, but it's always there, it's always present. The anxiety and worry are associated with 3 or more of the following 6 symptoms, present often for at least 6 months. So when you have a patient in clinic and you from all indications, this patient seems to have anxiety disorder, you want to know what type. Is it generalized anxiety disorder? And it's good to note that generalized anxiety disorder is actually very common with patients with chronic diseases.
Yes.
Chronic diseases like heart failure, hypertension, diabetes. So let's make it a habit and form it as a culture that when we see patients in our clinics, in our different places of work, that we'll find a way to integrate assessment of anxiety disorders in patients with chronic illness. So what are the symptoms? These are very specific for GAD. Restlessness, easy fatigability, being easily fatigued rather, difficulty concentrating, irritability, muscle tension, sleep disturbance. At least 3 of these six symptoms must be present for you to make that diagnosis. And not just that, the anxiety, worry, or physical symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. Not just to make the diagnosis, you also want to know, is there any functional impairment? And then the disturbance, you must also note that it should not be explained by another mental disorder. It's not due to depression, it's not due to any other type of mental disorder. Then you have arrived at your diagnosis of generalized anxiety disorder. So this is very important. It's very, very common, and it's something that we shouldn't gloss over. Imagine a patient comes to you, you've prescribed your antihypertensives, anti-failure regimen, anti-diabetic drugs, and the patient goes on with his anxiety, so you've really not done so much for that patient. So it's very important to integrate a biopsychosocial approach to medical care when caring for patients, not just the medical, also look at the biopsychosocial aspect so that we're able to address issues such as this.
Sure.
So this is like a depiction of what I just mentioned, the 6 symptoms of generalized anxiety disorder. So please, let's try to remember that. It will help us in our day-to-day practice.
And then next is a panic disorder. So panic disorder is characterized by episodic, unexpected panic attacks which occur without a clear trigger. So panic disorders, they have a lifetime risk of about 1.4 to about 3%. And panic attacks are defined as a rapid onset of intense fear, which typically peaks within about 10 minutes, with at least 4 of the symptoms criteria in the DSM-V diagnostic criteria. So this person worries about the next attack and modifies their behavior in a maladaptive way to avoid them. So for the panic disorder, we have recurrent unexpected panic attacks, with 4 or more symptoms of the following symptoms. So they can either have palpitations, which is awareness of one's heartbeat. You notice they are sweating a lot, they're either trembling or they're shaking. They can't breathe, shortness of breath also, or difficulty in taking in air, feelings of choking, and then chest pain. So the guest or the patient has to have at least 4 or more of the following symptoms before you diagnose it as a panic disorder. They can also have nausea or abdominal distress. There can be dizziness or lightheadedness. There can be chills or heat sensation. They can also have paresthesia, which is abnormal sensations in the body. They can also have derealization, so they don't know what is real or what is not real. They can't separate the two. Fear of going crazy and fear of dying. Okay. So this is a graphic representation of what we just talked about. In a patient with panic attack, they can either be sweating, accelerated heart rate, they can be dizzy, trembling, or fear of losing control or dying.
So to make a diagnosis of panic disorder, according to the DSM-5 criteria, so this is another way of quickly, making your diagnosis straight to the point. So all those symptoms that we mentioned are symptoms of panic attacks. At least one of the attacks has been followed by at least 1 month of one or more of the following. Now, they will have persistent concern about having another attack. When will be the next one? In fact, sometimes they think they're having a heart attack and they will keep coming to the clinic. They will keep coming to the emergency room, but it's actually a panic disorder. They worry about the implications of the attack. That is what I just meant about, fear of having a heart attack, worrying about death, fear of dying, which is one of the symptoms. There'll be a significant change in behavior related to the attacks. The panic attacks are not due to the direct physiologic effects of a substance. So during your history taking, you have to find out about the psychoactive substance use or a general medical condition like hyperthyroidism. The panic attacks are not better accounted for by another mental disorder as well. So panic attack is definitely intermittent, but there is no known trigger. You cannot pinpoint the stimulus that is triggering this panic disorder, unlike when we talk about specific phobia, which is the next one. So for specific phobia, it is an anxiety disorder characterized by excessive and irrational fear of a particular object, situation, or activity. I have a fear of dogs.
Really?
But it's not to the extent of having specific phobia. Some people have fear of needles, fear of flying, fear of the water, and things like that.
I don't have that.
The intensity of the fear is usually disproportionate to the actual danger posed by the phobic stimulus. They include fear of heights, like acrophobia, fear of spiders, like arachnophobia, fear of flying, aviophobia, and fear of needles, trypanophobia. We must have seen people, patients in the course of our work that have very, very bad fear of needles.
True,
And they're telling, keep your hands. No, they have phobia to those type of situations. Those are specific phobias. So for specific phobias, it's intermittent. It's not all the time.
Yeah.
There's a trigger. There's a known trigger. It could be flying. It could be water. It could be dogs such as me, or it could be needles. So these are some of the situations. So the specific situations, there are actually 4 major specific phobia categories. Natural environment like thunderstorm, astrophobia, raindrops, hydrophobia, then dendrophobia as well, trees.
Yes.
Then you have mutilation or medical treatment, dentophobia, people that don't like anything, that's dental procedure. Hemophobia, fear of blood. Once they see blood, they pass out,
Yes.
right?
Yes.
Then trypanophobia, which is fear of needles. You also have that for animals, echinophobia for horses, and so on. Then situations, like we said, claustrophobia is also a specific phobia. Being in the elevator, just be sure they are going to pass out. And then glossophobia as well as aerophobia. So this is just a way of simplifying it so that when we say this, we come across it, we tend to remember. So this is a concept. So you have to specify specific phobia. Is it animal, natural environment, blood injection injury, situational, or others?
So for the specific phobia DSMV criteria, so there is marked fear or anxiety about a specific object or situation, as my chief has talked about. So the phobic object or the situation almost always leads to an immediate fear or anxiety. So when they see it, either be dogs or water or trees, they get anxious immediately. The phobic object or situation is actively avoided or endured with intense fear or anxiety. So if they know they are going to see what they are scared about, they will do everything in their mind to evade it. The fear, anxiety, or avoidance is out of proportion to the danger posed. It is persistent, usually lasting for 6 months or more. The fear, anxiety, or avoidance causes significant distress or impairments in their social, occupational, or other important areas of function in other walks of life. And it should not be better explained by other mental disorders when we're making a criteria for it.
So the next important one is social anxiety disorder. Social anxiety disorder, I think it used to be called social phobia, but it's now social anxiety disorder by the DSM-5 text revision criteria. So it is characterized by excessive fear of embarrassment, humiliation, or rejection when exposed to negative evaluation by others during a public performance or social interaction, when in social gatherings, attending a wedding or parties, or having to make a presentation in the presence of multitude of people, they feel like they are being negatively judged or assessed, and it can be really, really terrible. Risk factors include genetics, like we mentioned, observing others with social anxiety disorder, so it can be learned, early traumatic events, parenting styles, people that are too sheltered. That's why you mistake them for being shy, but it's not shyness. They actually have social anxiety disorder. Isolated upbringing. Only children that are just the only kids in the house tend to, or parents that don't allow their children socialize. No, don't talk to the neighbors. No, I don't want you to go to your friend's house. Things like that. It tends to build this side of type of fear and anxiety, and then social expectations too can be a trigger. So signs of social anxiety, like we mentioned, fear in some or most social situations, almost all social situations, they rather be indoors in their room than venture out, to mix up or socialize. Fear of being embarrassed, blushing, sweating, or trembling in social situations. You see them with a microphone and their hands are shaking, they are stuttering, it's as if they're going to pass out. Avoiding social situations like partying or hanging out. Overanalyzing past social interactions. Oh, when I did this, there was a way that man looked at me or that woman looked at me, and they begin to overanalyze, and then fear of being judged or embarrassed or rather humiliated. So for social anxiety disorder, the criteria now is: one, there will be pronounced fear or anxiety around one or multiple social situations where a person is possibly exposed to scrutiny by others. There's no way you'll be in a social gathering, people will not look at you from head to toe,
Yes.
but if you don't have the precipitant or this disorder, you're likely to feel any way about it. But for people who really have this social anxiety disorder, it's really, really bad. The person fears they may act in a way that may be evaluated negatively. The social situation mostly evokes anxiety or fear. The situation is either endured or they rather don't be there at all or avoided entirely. The fear or anxiety is disproportionate to the threat posed by the situation. You see them shaking like a leaf and you're wondering what's going on, but there's nothing wrong. Everybody's minding their business, but they don't really understand it that way because they can't really control it. The avoidance, fear, or anxiety lasts for at least 6 months and causes significant impairment in an area of functioning. It can be in any area of functioning: work, personal life, relationships. Most times, people with social anxiety disorder, they usually have relationship issues.
Sure.
Some of them end up being single because of this. It is not attributable to the effects of a substance, medical condition, or a different mental disorder.
So the next one is agoraphobia, which involves anxiety or fear with thoughts that escape might be difficult or impossible in various situations. Individuals with this tend to avoid these situations, and in severe cases, they might become homebound or be indoors for a long time. They might need support and they're really dependent on others for basic needs. Approximately 90% of these individuals have comorbid mental disorders. So there's usually something else that is the cause of agoraphobia, not by itself, and about 15% experience suicidal thoughts or behaviors. So agoraphobia, the signs and the symptoms: so fear of crowds or waiting in line. There's fear of public places. There's fear of using public transportations, fear of leaving the house, fear of enclosed spaces and open spaces, fear of being alone. So according to the DSM-V criteria, it is characterized by marked fear or anxiety about at least two of the following 5 situations persisting for at least 6 months. So there should be at least 2 of the 5 situations mentioned below, and should be for at least 6 months. So using public transportation, if they are being in open spaces, being in enclosed spaces, if they're standing in line or being in a crowd or being outside the home alone. So this fear or anxiety leads to actively avoiding them and resulting to significant distress and functional impairment. The fear or anxiety cannot be attributed to realistic threats, sociocultural factors, substance abuse, or withdrawal. So they're generally just scared of being out in the open if they know they can't escape a certain situation, be it public people, being in open spaces where they can be judged or talked about negatively.
All right, so these are some of the clinical presentations from cognitive symptoms, physiologic symptoms, behavioral symptoms, and even affective symptoms. So for cognitive symptoms, some of them is fear of losing control, detachment, hypervigilance for threats, hyperarousal, fear of death, confusion, even poor concentration. Physiologically, they'll start having palpitations, shortness of breath, choking sensation, sometimes chest tightness, rapid breathing. They come to the clinic, you're doing ECG and troponin I, dizziness and trembling, nausea and stomach upset, diarrhea, tingling of arms and legs, and so forth. Then behavioral symptoms will be hyperventilation, difficulty speaking, and avoidance. So in the management of anxiety disorders, just as in the management of any mental disorder, history taking is very important. It's from your history that you're able to elicit the symptoms, to be able to pinpoint what type of anxiety disorder the person has. Also take a good medical history. Remember we said not due to, we keep saying not due to any medical condition, hyperthyroidism and things like that. And then psychiatric history. Do they have any other mental disorder? Medication history, are there medications that could be triggers? Forensic history, meaning have they had problem with the law in the past? Personal history, you want to know the birth history, education, work history, and things like that. Family and social history, remember that people who have good social interactions, it actually helps to ameliorate anxiety disorders. Pre-morbid history, and if they have insights, do they understand what the problem is? Then you do a mental state examination for those of us that did their psychiatric posting. So you check for appearance, behavior, speech, the rate, volume, mood or affect, thoughts and perception, insight, like I said, and then if they have good judgment. Physical examination, you do a thorough general examination and systemic examination as well. Now, it's important to note that for you to elicit anxiety disorders, like I said earlier, the biopsychosocial approach. So you need to FIFE your patient. In family medicine, we call it FIFE. You want to know what are their fears. It might be that somebody died in their office 6 months ago, and since then, I've been thinking maybe it's my turn to die, or they lost a loved one, or things like that, or maybe they were really abused, and so forth. Then you want to find out what do they think is the cause of the problem, and then you want to also assess functional impairment. How has it affected your day-to-day function? And then their expectation. Patients might just come for a drug refill, but there's something else that brought them, which could be just anxiety because of a chronic illness. So you have to find out what the expectation is. What is it that they want to achieve? I don't want to feel like this anymore. Doctor, how can you help me? Except you delve into the psychosocial aspect of their illness, they'll just keep coming with the same problem and the same issue. Before you know it, they go to Google and then still no help in sight. Investigations that come now, these investigations is not necessarily to diagnose anxiety disorders, but you also want to rule out other underlying medical condition. Some screening tools that can be used for anxiety disorders is your GAD-2, Generalized Anxiety Disorder Questionnaire 2, which we'll show in the next slide, is something we can apply in the primary care setting, quickly screens for anxiety disorder. Then you can now further use your GAD-7, which has 7 questions. And when you've assessed that and you've established your diagnosis, then you can further assess the person using your Hamilton Anxiety Rating Scale or your Beck Anxiety Inventory by. So this is the GAD-2 questionnaire.
So for the GAD-2 questionnaire, you'll be asking the patient over the last 2 weeks, how often have you been bothered by the following problems? So you would have a place where it would not at all, several days, more than half the days, or nearly every day. So the first question is the patient feeling nervous, anxious, or on edge. They can put not at all, several days, you give it 1 point, more than half the days, you give it 2 points, nearly every day, you give it 3 points. If they're not being able to stop or control their worrying, which is something that is paramount to mostly all generalized anxiety disorders patients, not at all, like I said, 1, several days, not at all 0, several days 1, more than half a day 2.
So any answer 2 and above 2 with there's a problem. So you need to delve deeper, and try to manage the patient appropriately. So management options, you have the non-pharmacological management, which is ideally should be the first line before you talk about pharmacological management. Sometimes, especially in generalized anxiety disorder, combination therapy is also quite, there's room for combination therapy, especially when one is not working as it should, then you add a second management plan. So for non-pharmacologic management, psychoeducation. Psychoeducation is what we can actually offer. We are not behavioral physicians, but it's what you can offer in the clinic. When a patient, the first line, that before you start referring for psychotherapy, you're telling the patient, you're listening definitely. You try to listen to the patient's fears, anxiety, try to get to the root of the matter, then educate the patient on what the problem is. Educate them, give them facts. Let them hear it from you, the doctor, than Google. Okay, so give them facts of what the illness is about. Let them feel heard, let them feel seen. And then you also outline a management plan. Let them know that there's a solution to this. Also offer help. It can be relaxation techniques. It can be positive psychology. It can be lifestyle modification. Give them a form of therapy. And then before you can now talk about referral to the behavioral physician for the other outline, which is the psychotherapy. Predominantly cognitive behavioral therapy. Then you have behavioral therapies like relaxation training and mindfulness techniques. Lifestyle and self-management. Lifestyle modification has a role to play in anxiety disorder. And then there are other complementary approaches like deep breathing, yoga, acupuncture, and things like that. So for cognitive behavioral therapy, is a very effective and evidence-based therapy for anxiety disorders. Now, the core principles of cognitive behavioral therapy in anxiety disorders is not to negate the negative thoughts, the negative intrusive thoughts, and focus only on the positive. No. We know that anxiety is maintained by distorted, warped thoughts and avoidance behavior. Challenging and restructuring those negative thoughts helps the patient, to come out of it. Exposure to feared situations as well as skills training. So it is a combined effort by the therapist as well as the patient. You're not just telling the patient what to do, but the patient is also involved in that therapeutic session. So part of cognitive behavioral therapy, that's also is the first line that you can offer, if not for anything else. Before you start writing your sertraline, paroxetine, and the rest, give brief psychoeducation. It won't take more than 5 minutes. Then you have cognitive restructuring, systematic desensitization, behavioral experiments, relaxation training exercises, problem solving and coping skills. Help them with how they can cope with such situations, and then relapse presentation. So for relaxation and mindfulness techniques, it's being in the present, being mindful. You're not trying to suppress what you're feeling. The tremors, the sweating, the palpitations, you're encouraged to feel those and to analyze it, knowing that there is no threat here. It's something that you can control. Progressive muscle relaxation, deep breathing exercises helps. Mindfulness mediation, guided imagery, looking at imageries that help the psyche, and then grounding exercises as well. All right, so lifestyle modification. If you use the 6 pillars of lifestyle, diet and nutrition has a role to play. If not for anything, for generalized well-being, whole food plant-based dietary pattern is advocated. Eating of non-starchy vegetables, plant-based diets like your peas, beans, and all actually helps the gut microbiome, which is connected to brain function as well as helping with weight control, which inadvertently can actually help to improve the person's feelings and anxiety. Physical activity or exercise is also very important. Restorative sleep, stress management. Now we'll go into sleep later in insomnia. Now, stress management and emotional wellness, time management. Teach them one or two things on how to cope with anxiety. It might be in the workplace, it might be in the home, through therapy as well. Smoking cessation and avoidance of risky substance. That's why you need to ask about smoking. You need to ask about use of risky substances like cocaine. Then connectedness and positive, to encourage them to have positive social connections. Very positive, in life. You can encourage a gratitude. Every morning they wake up, they can write
Yes.
and you will see that improves their mood as well. Let's talk about the complementary approaches.
For the complementary approaches, movements like therapeutic yoga, which has been known to help people with anxiety, it is a relaxating and a calming physical fitness also that we do. Breathing tools, abdominal breathing, taking a deep breath, also lengthening your exhale. So when you take a deep breath, you can pause and then lengthen you as you're exhaling out. Also self-expression, anything you like. If you know dancing makes you happy, singing makes you happy, making acts makes you happy, you do that also. Reading, there are books also, so many books being motivational, books that help you see a better outlook on life that you can read on. Massages, be deep tissue massages, acupuncture, which is very good also, listening to music. Then community, be spiritual activities, going to church, volunteering in things that you know that can help your community. Quality time with your family and friends can also help patients with generalized anxiety disorders.
So the pharmacologic management of anxiety disorders, using antidepressants like serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, tricyclic antidepressant like your amitriptyline, monoamine oxidase inhibitors like phenelzine, and then benzodiazepines, which is only used, that's why it came last. It's usually used in the short term for panic attacks. It's not what you give your patient when they come with anxiety disorder, please. It's just in the short term for panic attacks, usually. So there's a list of several of the selective serotonin, that is the SSRIs. Fluoxetine can be used about 10 to 20 milligrams per day, especially for panic disorders. And then you have citalopram, which is about 10 to 40 milligrams per day. You can use it for panic disorders as well as generalized anxiety disorders. Sertraline, citalopram for generalized anxiety disorders as well, paroxetine, and the rest. Now, venlafaxine and duloxetine, they are called the serotonin norepinephrine inhibitors. They're especially used in generalized anxiety disorders. These other pharmacologic agents like the TCAs, monoamine oxidase inhibitors, are not really first line per se, but I put it out there because they can also be used. Beta blockers may also be used, especially in panic disorders like propranolol and atenolol. All right.
So anxiety disorders and chronic medical conditions. So anxiety disorders have shown to have a bidirectional relationship with chronic diseases like diabetes mellitus, hypertension, heart failure, and stroke. Like my chief said, this is mostly seen in guests that have chronic illnesses. So it goes both ways. They will always be worried about their illness. Then there's integrative or collaborative approach to care. Is important in improving the management of patients who not only have this debilitating illness but is also compounded by mental health disorders. So there's need for assessment of such persons during routine health visits in the clinic through history taking and the use of the assessment tools like we mentioned, the GAD2, which if they're positive, you progress to the GAD7 and then HAM-A. The referral to behavioral physicians and psychologists for CBT improves outcomes in patients with comorbid medical conditions and mental illnesses. So it has been certified that this patient has generalized anxiety disorders from your psychoeducation that you from the GAD2 that you did, you could refer the patient to behavioral physicians or a psychologist for expert management and care. Social support is also an important aspect of care, such as the cardiac care heart failure support group, which is very much active till now, which helps patients with heart failure deal with mental stress and anxiety associated with this illness. So it's good to meet other guests and know that you're not alone in this.
So the heart failure support group usually occurs takes place every first Saturday of the month. So it's actually a tangible approach by cardio care to help our heart failure guests who are going through the burden of a chronic disease such as heart failure that comes with a lot of mental stress, anxiety, and even depression as well. So we should form a heart great social. So even drugs assess the social aspect, some depression as well. So most of them can actually, so this is very important. In our different centers, we might actually start our own support groups. It can be for hypertension, can be for diabetes, but for cardio care, we already have a strong support group that also channels a lot of care and in mental disorders, such as anxiety disorders, because there's fear of dying with heart failure patients.
Yes.
You wake up in the middle of the night gasping for breath, you're thinking that is your last breath.
Yes.
So these things occur every day and should not be ignored. All right, so look briefly at a case study before going back to the MCQ that were projected earlier. Mrs. CB is a 40-year-old banker, presents with a 7-month-old history of restlessness, poor concentration, difficulty sleeping, and fatigue. She worries excessively about several things: work, children, finances, and husband. She denies panic attacks or depressive symptoms. She has no history of substance use or significant medical history. What is the most likely diagnosis and why? So we're going to know who has been paying attention. Please, this is an interactive session. Feel free, very much free to share your answers, and we can go through it. Then B, what are the non-pharmacologic and pharmacologic modes of management? So just in a few seconds, let's feel free to post our answers. We'll know who have been paying attention. So here, note the duration is above 6 months.
Yeah.
Note the particular symptoms she presented with. There's restlessness, poor concentration, difficulty sleeping, and fatigue. That's 4. And then note that it's excessive, and note that it cuts across several aspects of life, and then is not due to any other mental disorder, not due to history of substance use or any medical history. I think I've given you the answer. So feel free to post your answers in the chat box. Okay, are we together? Hello? Oh my goodness. All right, so I'm sure we've all been paying attention. For the sake of time, we'll go to the next session, which is, we'll still come back to this if we have time, insomnia. All right, so like I said, this is a combination of 2 major topics, but we'll try to be fast. For insomnia, this is a brief pretest. What is the diagnostic duration for chronic insomnia?
Acute and chronic insomnia. So we'll talk about the stages of sleep. So this refers to a specific stage of sleep characterized by a deep, uninterrupted sleep that promotes physical, mental restoration, healing, recovery, and rejuvenation. Obviously, as an adult, after work, we need sleep, obviously. So we all know that it promotes physical and mental restoration, healing, and then rejuvenation for the next day. So for the stages of sleep, we have the NREM, which is the non-resting eye movements, which occurs in 75 to 80%, and then the REM, which is the resting eye movement sleep, which occurs in 20 to 25% of total sleep. So for the non-REM sleep, Stage 1, there are 3 stages. So for the stage 1, there is light sleep. It is made up of low amplitude, mixed frequency activity. So this stage lasts about 1 to 5 minutes. And then for the stage 2 is a deeper sleep characterized by theta waves with K-complex waves and sleep spindles. So this comprises of about 50% of our sleep. And then stage 3, this is the deepest, is a non-REM sleep with mostly delta waves. Then the second type is the REM, which is the dream sleep, 20 to 25%. It is not considered a restful sleep here. The muscles are tonic, there is eye movements, there is erratic and irregular breathing. Usually begins 90 minutes after you start sleeping. So the brain metabolism also increases by about 20% in the stage.
Okay, so how much sleep is enough? According to American Academy of Sleep Medicine, the AASM, so these are the duration for different ages, from infants to children to teens and adults. So adults aged 18 years or older should have an average of 7 to 8 hours a day. Some would say 7 to 9 hours of sleep per day. So I don't know how many of us, the last time we slept for 7 hours, actually health workers with the shifts and all, whether we actually do sleep up to 7 hours a day. That would be really fantastic. But this is what is recommended, not 6 hours, not 9 hours, and not above 9 hours, but 7 to 8 hours, or even 7 to 9 hours per day. So the causes of acute and chronic insomnia cannot be attributed to one single factor and is poorly understood. Acute insomnia involves a combination of environmental, genetic, psychological, and other behavioral factors. Chronic insomnia has more comprehensive interactions. There are some predisposing factors, precipitating factors, and then factors that perpetuate chronic insomnia. About 1/3 of adults report at least one symptom of insomnia. I think almost, yes, about 1/3. If I'm seeing like 10 patients in a day, I'll say 3 to 4 would say, doctor, I did not sleep well yesterday. I've not been sleeping well in the past 6 months. So we come across this. So I hope that by the end of this insomnia presentation, we'll have a practical approach to managing this as well. Prevalence of insomnia range from 6 to 10%. It's common among middle-aged and older adults, women as well, especially menopausal women, shift workers like the nurses, the doctors, and so forth, and patients with comorbid medical and psychiatric disorders. So according to DSM-5 test revision criteria, 4% to 22% of adults meet the diagnostic criteria for insomnia. So we won't really go into details because of the sake of time, but these are some of the interaction that leads to insomnia. The psychopathology, it ranges from it starts with the predisposing factors, which we've mentioned, and then the precipitating factors, and then the perpetuating factors like behavioral adaptation, example, long time in bed. Some people just, even when they're not sleeping, they just want to be in bed. Extended sleep opportunities like daily naps. Taking naps in the afternoon really affects your circadian rhythm, and then that affects sleep. Other perpetuating factors like hyperarousal, the cortical, like sleep focusing and attentional bias, and then you have some back and forth with emotional and the autonomic. So at the end of the day, you have poor cognitive performance, poor memory consolidation, and then emotional dysregulation, which leads to the psychopathology. So the pathophysiology of sleep. Now, we can't talk about sleep without mentioning the circadian physiology. We all know about the body's rhythmicity rotating around 24-hour period. In fact, it runs like for 24.1 to 24.4 hours. The master circadian clock is actually in the suprachiasmatic nucleus in the hypothalamus. The detection of light brightness versus light exposure duration is important, which we'll talk about in the next slide. So identifying timing of light exposure can help improve sleep health. That is why when you wake up in the middle of the night to pee and you on the lights, it will take time for you to go back to bed. Yes. When you're using your phone shortly before sleep comes, sleep won't even come. It's going to advance your sleep circadian clock, thereby preventing sleep to come earlier than it should. So in an adult with a synchronized circadian clock, there's promotion of health and wellness. So the next slide tells us about the phase response curve. For you to have a restorative sleep, we'll talk about the phase response curve. So this is a graphical representation of what I'm about to say. It starts with light during the day, like now, in the afternoon. Light during the day does not affect your circadian clock. If you step outside the consulting room to go outside, maybe to take a call or something, it won't affect your sleep at night. Light around evening delays melatonin and the clock by 30 minutes. Let's say in the evening, say around 6 p.m., you're in your room, lightly read, like the light blasting right now, it's going to actually affect sleep, suppressing melatonin, which is a sleep aid, a sleep hormone, and then the clock will be delayed by 30 minutes. Now, light during the early part of the night, for instance, you want to go to bed around 9 p.m., but by 8 p.m., you're pressing your phone, you have a presentation, crash program, you need to put some things in order, you're watching Netflix, you have a television with bright lights. So those lights around the early part of the night has a bigger impact, and it will delay the clock by an hour, 60 minutes. Meaning that you think you're going to go to bed by 9:10, your eyes are still bright. There's no way you can fall asleep. Now, when there's light exposure at midnight, like I said, it produces about 60 minutes advance in the circadian rhythm. So you're going to wake up earlier than you should. You want to go to the bathroom, you're on in the light. Try as much as possible to do it in the dark without bumping your feet. Light at the end of the night, maybe early hours of the morning, is healthy for maintaining a circadian rhythm. That is why your mom comes into your room, draws up the curtain, it's time to wake up, or you're waking your kids for school. That helps to actually produce a 30-minute advance in the circadian clock. So this phase response curve is actually very important. So types of insomnia based on the duration.
So we have the acute insomnia. The duration usually days to few weeks, usually triggered by situational stressors like illness, work, normal stress, or loss of a loved one. It is not due to a medical condition, medication, or substance abuse. Now, for the chronic insomnia, the duration is greater or equals to 3 months. It occurs more than 3 nights per week. So if a guest comes in and says she hasn't been able to sleep for 3 or 4 days in a week, you can already get
more than 3 months duration.
Yes. It's associated with underlying medical, psychiatric, or behavioral factors as compared to acute insomnia. Now, for the transient insomnia, it occurs less than 1 week, often due to stress or environmental changes.
Now, most patients will actually come with this transient insomnia. Since day before yesterday, I've not been able to sleep, doctor. Work has been stressful, or I just got back from Kaduna, or things like that, So this is transient insomnia. So it's good to know the duration. That will help you to classify it accordingly, and then know how to approach the management. And then based on etiology?
Yes, so based on the etiology, we have the primary insomnia. So this is sleeplessness that cannot be attributed to an existing mental, or environmental cause. Now, for the secondary insomnia, this is lack of sleep, which arises from an underlying medical illness, mental disorders, or sleep disorders. It may also be from the use of psychoactive substances.
Okay, so the criteria for insomnia by DSM-5, number 1 is a predominant complaint of dissatisfaction with sleep quantity. Quantity means how many hours, or quality. You didn't have a restorative or refreshing sleep associated with one or more of the following. Like you said earlier, difficulty initiating sleep, you're tossing and turning, you went to bed by 8 p.m., 11 p.m., you're still there, your eyes are bright and shining, and then difficulty maintaining sleep, you sleep for like 30 minutes to an hour, you wake up and can't go back to bed. Early morning awakening with inability to return to sleep. Instead of you to wake up by 6 a.m., you're waking up by 2 a.m. and you can't go. So these are various things we hear our patients say, even ourselves too. Sure. Some of us have those sleeping issues. And then the sleep disturbance causes clinically significant distress in social, occupational, you're at work and you want to doze off. You are fighting the sleep and you just can't help yourself. Educational, it causes poor concentration, loss of memory, impairment and things. You can't consolidate what you're reading. Behavioral and other areas of functioning. Another important point is the sleep difficulty occurs at least 3 nights per week. The sleep difficulty is present at least 3 months. The sleep difficulty occurs despite ample opportunity for sleep. Not like you deprive yourself the time to sleep. You went partying or clubbing and you expect to still have 6-7 hours of sleep. That will not be the case. The next point is insomnia is not better explained by and does not occur exclusively during another sleep-wake disorder. It's not due to jet lag. It's not due to other type of sleep disorder. Remember that this presentation is focused on a particular type of sleep disorder, which is insomnia disorder. The insomnia is not attributable to the use of a substance. Coexisting mental disorders and medical conditions do not adequately explain the predominant complaint of insomnia. Specify if it occurs with a mental disorder or a medical condition or another sleep disorder. You also need to specify if it's recurrent, persistent, or episodic.
All right,
so what are the clinical presentations?
So for the clinical presentations, we have either a nighttime symptoms you can have or a daytime symptoms. For the nighttime symptoms, there's difficulty initiating sleep, so greater than 30 minutes, like my chief said. You try to sleep by 9 o'clock, you notice by 11 p.m. you're still tossing and turning. So more than 30 minutes have been given before you could initiate sleep. There's difficulty staying asleep. There's early morning awakening and poor quality sleep. For the daytime symptoms, there will be fatigue because you couldn't sleep the nights before, low energy, daytime sleepiness, poor concentration, mood disturbances. You can be agitated or irritable. There's reduced function either at your workplace or at school, and increased risks of errors and accidents.
So these symptoms will help you to know what to ask, questions to ask, not just, "Doctor, I could not sleep last night, just gloss over it. How are you feeling? Any chest pain, shortness of breath?" But no, don't forget that the aspect of poor sleep also has implications in the patient's overall health and well-being. So you know what to ask during your history taking, right?
Yes.
All right. So in management of insomnia, history is very important. You need to take your history based on all these criteria and all the points we've listed and all the clinical presentations. It guides you in your approach and questions to ask. Then your sleep assessment using the relevant tools like the diary and all. And then investigations where applicable. The non-pharmacologic first, and then pharmacologic management if indicated. So in your history taking, you need to take, apart from the usual history surrounding the patient's presentation, other things might bring the patient to the clinic, but sleep would always be part of it one way or the other, poor sleep rather. So in your sleep history, you're asking about sleep timing, the number of hours of sleep and daytime naps. What time do you go to bed? What time do you wake up? Do you sleep in the afternoon? For how many minutes? For how many hours? What time do you sleep in the afternoon? What time do you wake up? Very specific questions. Sleep habits around bedtime. Is that when you take a glass of alcohol? Drink coffee? Time it takes for you to fall asleep. For most people that they fall, you might lay down the number of times one wakes up and how long it takes to go back. Sleep quality is also the by 100. You're calculating it. You know whether the sleep is good or not. Snoring, talking about OSA, obstructive behavior during leg movement, daytime functioning affected, personal habits like what I said earlier. So sleep history can be quite detailed. We also ask about history of pain. These are things that can affect the person's sleep. Neurological, psychiatric disorders, medical and psychiatric history, medication history. So medications can affect sleep, especially when you give patients diuretic. We always cancel our patient heart failure guests who will give torsemide or furosemide, because they always complain that this medication makes me wake up several times at night to urinate, and once I get up, I can't go back to bed. So we usually tell them to take the last dose maybe around 5 p.m. earlier in the day, so that by the time they sleep, they've already exhausted all the urinary frequency, so that they can have a good sleep. And then level of exercise, substance use, psychosocial stressors, and the shift work. So these are the assessments guidelines recommended in maintaining a sleep diary. Guidelines recommend maintaining a sleep diary for 1 to 2 weeks. There are other validated skills as well, which we don't usually use commonly, but it's good to know them. All right, next.
So for the assessments, the sleep vital signs. So sleep problems are...
Oh, sorry, I want to know that sleep should also be a vital sign. You know, it's something that you should always ask your patients in clinic when evaluating them about, you know, if any sleep problems is present.
So sleep problems are normally associated with a variety of cardiovascular diseases. Individuals with poor sleep usually report poorer health, lower quality of life, and increased use of medical resources. So sleep assessment tools that we use, it can be objective or subjective. For the objective, we have the polysomnography and the actigraphy. And then for the subjective, which is what the guests will do themselves, we have sleep diaries. There's a single item sleep quality scale, which is the overall sleep quality in the past 7 days, yes. So it can be 0, terrible, and 10, excellent. Then the stop bank questionnaire, which includes about 7 questions: snoring, tiredness, observed apnea, gender, which are also used. These are tools that are used to check the quality of sleep in patients.
Okay, so how do we apply the sleep quality scale? It's actually a very simple thing that I can apply in clinic. You ask the following questions. Your overall sleep quality for the majority of nights, like in the past 1 week, how well have you slept? What do you think the quality of your sleep is? If you're to rate it on a scale of 0 to 10, right? Such as it will include how many hours of sleep you got. Okay, look at how easily you fell asleep, how often you woke up during the night, how often you woke up earlier than you should. So and then how refreshing your sleep was. So the patient will put all those pieces into consideration and then rate his or her sleep on a scale of 0 to 10. So 0 is terrible, 0 to 1. 1 to 3 is poor sleep. If the person is telling you it's between 4 and 6 or falls between 4 and 6 is fair. Anything that falls between 7, 8, 9 is good. 10 is always an excellent. And you have the stop bank questionnaire.
So for the stop bank questionnaire, the first is snoring. If the guest or the patient snores, tiredness, do you often feel tired? Are you fatigued?
Remember that is for obstructive sleep apnea, which can affect sleep.
Yes. So tiredness, do you often feel tired? Are you easily fatigued? Do you sleep during the daytime? Observed apnea. Has anyone observed that you stop breathing, or you choke or gasp during your sleep? Or have you noticed that you yourself woke up in the middle of the night on such occasions? Any history of high blood pressure? Do you have, or are you being treated for high blood pressure? Your BMI. Is the body mass index more than 35 kg per millimeter square? Your age, are you older than 50 years? The neck circumference, is your neck greater than 40 centimeters? For men, the ideal is 17 inches, and for female, 15 inches. And gender, are you male?
Yes, there's additional questioning for this stop bank questionnaire, whereby if the person has 2 or more stop answers, that is the STOP, plus high blood pressure is significant. If they have 2 or more stop questions plus BMI greater than 35 kg per meter square is significant. If they have 2 or more stop questions plus neck circumference greater than 43 inches in men or 40 cm in 43 cm in men or 40 cm in women is significant. Or being male with 2 or more stop questions, that's also significant. It means you need to probe further and manage adequately. Then you have your sleep diary. We could actually have this in our consultation rooms, where we can give patients with, especially those with chronic insomnia, to take home and record their sleep habits.
Yes.
What time they went to bed, what time they tried to go to sleep, how long did it take to fall asleep, how many times did you wake up, not counting your final awakening. In total, how long did these awakenings last, and what time was your final awakenings? What time did you get out of bed for the day, and how would you rate the quality of your sleep? It's rated very poor. Each column is very poor, poor, fair, and good. So this could actually be part of our daily consultation. For those with poor sleep, they'll keep a sleep diary for at least a week, and then by the time they come back, you now reassess. But it's also important to know what to do when they come back with the sleep diary, which is where we're going
to talk about it. Yes.
So investigations are not really routinely done. Remember that patients come with other medical conditions, yes, but then sleep, problem with sleep would be part of their presenting complaints. Yes. So you also want to rule out any other underlying medical condition as applicable. Now, going to the management, which is the crux of the matter, non-pharmacologic management trumps pharmacologic management anytime, anywhere. So for the non-pharmacologic management, cognitive behavioral therapy for insomnia. I don't know how many of us are aware of CBT as a treatment for insomnia. We are too quick to give yes, benzodiazepines, yes, and all, from the diazepam to what's this common one, bromazepam and zopicone and all, and the patient keeps coming back. Now, the problem is that those benzodiazepines, there is risk of tolerance and addiction. 1, 2, they don't really affect sleep for insomnia as such. It won't really move the needle. There's something called the crash night. Patients who don't sleep without those medications, by the 3rd or 4th night, they would fall asleep. And it gives them the false sense of security that is actually the medication working when it isn't. So that's why it's not the first line. So the recommended first-line therapy for insomnia is cognitive behavioral therapy for insomnia. Is a multi-component treatment, mainly behavioral therapy combined with cognitive restructuring to facilitate sleep. Insomnia is mainly caused by poor behavioral behaviors, precipitate insomnia. So it makes sense that behavioral therapy is part of its management. So the components of CBTI include stimulus control therapy, sleep restriction therapy, and relaxation training therapy. Others are sleep hygiene, lifestyle modification, and then other therapies like mindfulness, meditation, and acupuncture. So coming to stimulus control therapy is one of the CBTI. We can actually apply this. It's not that hard. So this is the single most effective single treatment for insomnia. It's based on behavioral principles that link to conditioning. It strengthens the bed. The bed is a cue, for it serves as a stimulus for sleep. So it strengthens the bed, that is your bed, meaning your pillow and your bed, your mattress, as a discriminant stimulus for sleep. So activities such as watching the television, screen time, your laptop and tablet, watching Netflix or CNN or reading are strongly discouraged. You shouldn't have a television in your room. Your phone should not be on around bedtime, in fact, about 1 to 2 hours before bedtime. So instructions you give for stimulus control therapy is limit activities in bed for sleep or intercourse. Any other thing should not be happening in that bedroom. It's either you're sleeping or you're having intercourse. That way the brain is trained to know that once your head hits the pillow, it's either sleep or the other. Yes. So when the patient is on the bed and tossing and turning, 15, 20 minutes cannot sleep. He needs to get out of bed. Sit on an armchair. Look for low-key activities that will precipitate sleep. It's not the time to now on Netflix and chill, right? It's the time to just look for something boring to do. It might be an old dusty newspaper from 10 years ago, or an old magazine, or your child's old textbook, something that will not really be interesting. And then you might just see yourself dozing off, then you go back to sleep. Repeat it several times until sleep occurs. So the point is that you don't spend more than 20 minutes on that bed, tossing and turning if there's no sleep. You need to get up. So that way, you're controlling the stimulus. That stimulus control is that this bed, once I lie down, your brain is conditioned that once you lie down on the bed, sleep comes. And it works. Like I said, it's the single most effective single treatment for insomnia. The next one is sleep restriction therapy. I don't know if you've heard about this. This is more technical, but I'll try to explain it and I hope you understand it. So sleep restriction therapy is based on the fact that stable bedtime and wake times will re-entrain and strengthen your circadian rhythms. Remember when we talk about the phase response curve, right?
Yeah.
So it depends on limiting the number of sleep hours with the idea that it might improve the sleep drive and sleep outcomes. You're trying to restrict sleep. That way, it stimulates the sleep drive, and at the end of the day, improves sleep quality. So the first thing you ask your patient is, you want to assess the base. That's where the sleep diary comes into play. Okay? Or you ask them verbally. You want to first assess baseline sleep duration. Remember that when you're assessing sleep quality, you have to assess, or sleep pattern. It's not just about the duration. You want to ask about the duration. You want to ask about time in bed. You want to also ask about the quality of sleep. Those three must be assessed for you to assess sleep pattern. Then, so when you first assess sleep duration, the patient will tell you, okay, I go to bed around 12:30 a.m. and I wake up around, or let me say I go to bed around 1 a.m. I wake up around 8 a.m. And then sometimes they would have discordant timings, weekday and weekend, TGIF,
Yes.
right? So some of us would like to sleep in during the weekend.
Yes.
And this causes a disparity in the time you sleep, go to bed during the week and at weekend, on weekends. The time you wake up during the week and also on weekends. So when you get the duration during the week, the duration on weekends, it might be that the sleep duration on weekdays is 4 hours. The sleep duration on weekends is 8 hours. 8 plus 4 is 12.
Yes.
You get an average, that's 6 hours. You work with 6 hours duration of sleep. You restrict the person's sleep to that duration. The next thing is you set a prescribed bedtime to equal their average baseline sleep, which is what I just described. The next step is the patient's wake up and bedtime should reflect this average baseline sleep. So what does that mean? So because it's a sleep restriction therapy, you want to reduce the duration of sleep for by 20 to 30 minutes. Okay. So instead of 6 hours, let them sleep for 5 hours, 30 minutes. So that would mean that you can set the sleep time for 12:30 a.m. and then wake up time by 6 a.m. That's 5 hours, 30 minutes. The next thing you're going to do is to start filling the sleep time, going backwards. Start removing, subtracting 15 minutes from that sleep time until the sleep time can no longer be filled with sleep. So what does that mean? 12:30 to 6 a.m. Week 1, they should go to bed by 12:30 and wake up by 6 a.m. Week 2, they should go to bed by 12:15 a.m. and still wake up by 6 a.m. They can set an alarm clock. Yes. Week 3, they go to bed by 12 a.m. and wake up by 6 a.m. Week 4, they go to bed by 11:45 p.m. and wake up by 6 a.m. By week 5,
increasing.
Yes. So you just keep increasing until you can no longer fill that sleep period with sleep. That's before you know it, the patient is getting at least 7 to 8 or 9 hours of sleep. It's a gradual process, but it works. I don't know if you understood.
Yes, perfectly.
I don't know if there's any other way to explain it.
You did it perfectly.
All right. So that is sleep restriction therapy. So you can talk about the relaxation therapy.
All right. For the relaxation therapy, it should not be used as a standalone treatment for adults above the age of 60. This includes regular deep breathing exercises, mindfulness, muscle relaxation, and yoga. So you could tell them to do deep breathing exercises before they go back to sleep, muscle relaxation, or to try to do a brisk yoga before sleeping. But
okay, so for sleep hygiene, this is what we all can do. If we can't achieve, we can't carry out the sleep stimulus control therapy for some of us that are board certified lifestyle medicine physicians, but we can actually do it. The way I explained it, I think is applicable.
Yes,
it's easy to apply. Or the sleep restriction therapy, sleep hygiene, anybody can use that to counsel their patient. It's the weakest, actually. It's the weakest approach, but it's better than nothing. So for sleep hygiene, it's often the initial suggestion made by medical providers. Remember, in clinic, that's the first line of action. But it's significantly less effective compared to CBT for insomnia. It generally involves environmental changes modifying lifestyle factors, and regular exercises. Now, you start with power naps. For those that nap in the afternoon, power naps in the afternoon cannot be later than 2 p.m. It can be beneficial if limited to less than 30 minutes, that is no more than 20 minutes. So even if you're going to nap no later than 2 p.m., it's going to affect your melatonin, it's going to affect your circadian rhythm by the time you want to get to bed at night. Adequate daytime hydration. Make sure you're well hydrated during the day. Tell the patient to limit daytime caffeinated beverages. Don't take lots and lots, cups and cups of coffee during the day. Eventually affects sleep at night. Stop work and stimulating activities 1 hour, 30 minutes, or even 2 hours before bedtime. Eliminate nighttime caffeinated coffees. You don't want to drink energy drinks or coffee at night. So you need to be able to advise the patients appropriately. Avoid alcohol within 3 hours of bedtime. Alcohol might help at the beginning, but at the end of the day, it will lead to fragmented sleep. Eat dinner earlier and eliminate after dinner and late night snacking. Some people are guilty of this. They wake up at 12 a.m., raid the fridge, and that's when they remember the pizzas and all whatnot, and cake in the fridge. Then avoid high sodium and spicy foods at dinner. Weight reduction through exercises, healthy lifestyle, and reduction of BMI if elevated. Remember how we mentioned BMI in the stop bank for obstructive sleep apnea. Then relaxation activities with bath or shower. Depending on the weather, you can have a cool shower if the weather is hot at close to bedtime. Comfortable bed. Your bed should be comfortable, not those hard mattress they call, I don't know what they call it. By the time you sleep and wake up, you are waking up with so much pain. Mitigate daytime worry. Nighttime worrying, actually. Planning and ruminating using mindfulness stress reduction. Minimize or eliminate bedroom noise and light. It's not when you want to play loud music. It's not when you want to on the TV or use your phone or gadgets. Remember, I said no TV or computer in the bedroom. Alarm clock out of sight and develop a wind down routine for moving from daytime concern to restfulness. Then decrease light in the night, turn off all devices, ensure warm extremities, wearing of socks. I do wear socks at night, blankets and all. Then meditation, guided imagery also helps. Some kids, and this is for children, the starlight and all that. It actually helps to promote sleep. And then lifestyle modifications.
So this basically entails physical activity. So be it aerobic exercises, 30 minutes for about 5 times per week. This improves the onset and the depth of your sleep. So you need to avoid vigorous exercises 2 to 3 hours before bedtime. Then restorative sleep. Your diet should be whole foods, plant-based, like you should avoid heavy meals before going to bed at the night. You should manage your stress also, be it relaxation techniques, deep breathing, yoga, evening journaling, guided imagery or mindfulness. So avoid substances like alcohol, nicotine, tobacco, or stimulants like caffeine and energy drinks. Positive social connections, which helps in stress reduction.
So all these non-pharmacological management for insomnia are actually very, very applicable. I don't know if we've been able to break it down enough for the audience to be able to apply that in their various centers with patients that complain of insomnia. They are actually, let's not form a habit of prescribing Zopicon, melatonin as first line. You can say that we put that at the all way, towards the back, because CBT should be the first line. The guideline states is the recommended approach for management of insomnia. So for the pharmacologic management, it's a generally weak mode of management and should not be used long term. We've already explained that it increases the risk of addiction without solving the sleep issue. I've explained the crash night effects, right? Non-benzodiazepine receptor agonists like Zopicon, we use this commonly, but shouldn't be the first line. Adjunct options like diphenhydramine, which is antihistamine. Melatonin is just a sleep aid. It's a sleep aid. Sedating antidepressants like amitriptyline, mirtazapine, trazodone, and low-dose doxepine. Doxepine, I don't think it's so readily available yet. Then the benzos are actually the ones that are quite common, but you have to use with caution and avoid it in the elderly. pregnant women and those with sleep apnea, such as flurazepam and bromazepam. So what are the complications of insomnia?
So for the complications of insomnia, impaired sleep leads to elevated sympathetic tone, which is seen in the guest. There will be elevated high sensitive therapy concentration. There will be signs of dyslipidemia at risk of type 2 diabetes mellitus or impaired fasting glucose. There's elevated nighttime blood pressure. There's increased risks of death from cardiovascular diseases. There's major depression and emotional distress and impaired learning or memory.
Yes, remember that highly sensitive CRP is a novel risk factor for future cardiovascular events.
Yes.
We do carry those tests in our centers. So that's actually one of the importance of highly sensitive CRP. In case you come across it tomorrow for a patient and you see it high, you need to counsel on lifestyle modifications. Okay. Next. Okay, so I hope we're able to beat the time as well as being able to break it down as much as possible so that we can apply this various modes of management for anxiety and insomnia in our day-to-day practice, be it primary, tertiary, or quaternary level of care. Patients will always come to you with symptoms of anxiety. They will always present with symptoms of insomnia. At least to a large extent, I believe we know what to do, what symptoms to look out for, how to approach the management. So when a patient comes to you with the symptoms, please take time to assess the biopsychosocial. Don't just focus on the biologic, what brought the patient. You also want to find out the real reason for this encounter. Patients come with fear. Some will come in the middle of the night with chest pain. That chest pain could just be anxiety. Yes, you do your ECGs and troponins and all, but if you don't address the real reason for the patient's encounter, which is fear and anxiety, maybe they've had a colleague died in the office, any small chest pain, they are afraid that it's their time to go. So please, 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 let's apply this in everyday practice. Speak to the patient, listen, communicate in terms that they can understand. Try to get to the bottom of the reason why they came in the first place. While we are refilling medications, treating other medical conditions, let's also know that mental disorders are actually very common, especially anxiety disorders in patients with chronic diseases, be it hypertension, diabetes, and heart failure. Insomnia is also a symptom of anxiety disorder. So they are all interrelated. They are not other. So please, let's take time to also educate the patient, examine them properly, assess them using the different assessment tools. We can have sleep diaries in our consulting rooms to be able to assess patients better, okay? And then involve them in the management and care plan. Let's always involve psychoeducation in our treatment plan. Let's always ensure cognitive behavioral therapy for insomnia, which is what this MCQ, this post-test is on, when managing patients with insomnia. Let's not be quick to prescribe melatonin, Zopicon, and all the benzodiazepines. Cognitive behavioral therapy for insomnia is easily applicable. With the way we try to explain it, I'm sure we can do that in our various centers. So for this post-test, in CBT for insomnia, stimulus control therapy, we took time to explain this. Please, you must get it right. Stimulus control therapy primarily aims to 1, restrict sleep time, B, decrease sympathetic overactivity, C, address catastrophic thinking about sleep, and D, strengthen the association between bed and sleep. Can we please post our answers in the chat box? Is the answer A, is it B, is it C, or D? Or have we succeeded in putting you to sleep before the end of the presentation? So please, what do you think the answer is? All right. Okay, so the next one is what?
Which of the following is not a component of sleep hygiene education? So A is avoiding caffeine in the evening. B is keeping a regular sleep-wake schedule. C is reducing screen time before bed. And D is taking long daytime naps to compensate for the lost sleep.
So which one is not a component? Remember, we kept stressing daytime naps during our discussion. So which one is not a component of sleep hygiene education? All right. Okay, so let's go back and answer those two questions before this.
All right.
So for the first post-test, what do you think the answer is?
I think it's strengthen the
D.
association.
Yeah,
between the
strengthen
bed
the association between bed and sleep. So the bed is like a stimulus for sleep.
Yes.
It's either for sleep or
Intercourse.
intercourse. If you're not doing either of the two, you should not be on the bed. Your patient should also not be on the bed. And it works. It's quite effective. Studies have shown that it's actually more effective than sleep restriction therapy. All right, the next.
The next one.
So what's the answer to this?
So I think it's taking long daytime naps to compensate for the long sleep.
Yes. Remember we said that you shouldn't be napping later than 2 p.m. during in the afternoon, more than 20 minutes, yes, and not later than 2 p.m. because it's going to affect your circadian rhythm, right? Yes. All right. Then the last post-test, okay, can we read out the question?
A 50-year-old banker complains of difficulty in sleeping for about 8 months. He uses alcohol at night to aid sleep. What is the best next step? A, prescribe bromazepam. B, begin CBTI and counsel on alcohol avoidance. C, start melatonin 5 milligram nightly. D, recommend afternoon naps.
Okay.
It should be easy.
It should be easy. We just concluded on that note. So will you prescribe bromazepam like we always go for? Or will you prefer melatonin, the substitute? Or will you tell him, oh, if you can't sleep at night, please sleep as much as you can in the afternoon? So which of these is the answer? Okay, let's look at this. Okay, all right. Okay, some of us posted our answers. Thanks for participating. This is fantastic. All right. Okay, so in summary, this brings us to the end of this presentation. But it's good to summarize on this note that anxiety can lead to mental hyperarousal with difficulty falling or staying asleep because worries from the day, Nigeria is hard for everyone. Worries from the day can carry over into the night. On the other hand, insomnia worsens anxiety. Like I said, they're all interrelated. Hence, this topic was chosen. It worsens anxiety by increasing stress and leading to a vicious cycle. So it can also be a symptom of an anxiety disorder. So it's good to have an integrated approach in evaluating patients who may have one or each of the other or disorder or both. Routine screening of anxiety disorders as well as evaluation of sleep disorders is really crucial to patient outcome. A prescription will remember how you helped him with insomnia than how you prescribed, refilled his antihypertensive or antidiabetic drugs. A heart failure guest would always remember how you made him feel by addressing his anxiety concerns than just refilling his medications and treating just the medical aspect. So please, 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 our consultations and management is never complete without addressing psychosocial issues such as anxiety and poor sleep in the care of our patients. Thank you for listening.
Thank you so much for listening.
Okay, there is a program coming up for all healthcare workers, doctors, nurses, and pharmacists. It's called Caring for the Carers. We'll care for our patients who care for us.
Yes.
Okay, so Caring for the Carers is a program that is coming up on the 15th of November by 8 a.m. at our head office, which is Limi Hospital area and a central area and cardio care hospital. So it's going to hold here as well as in CBD. That is the other branch at central area. So it's for physicians, for nurses, for pharmacists above the age of 40. We're not trying to discriminate, but it's actually for physicians, doctors, pharmacists, and nurses above the age of 40. We're going to provide free general health evaluations, personalized health reports, and then registration is free. Getting checked is free. You're not going to be asked to make any payments. We're going to carry out ECGs, chemistry profiles, screening via abdominal ultrasound, hepatitis screening, kidney function test, chest X-ray, and even a general physical examinations. You know, doctors are not in the habit of going to the hospital.
Sure.
Physician treat thyself, but right now we are proposing we treat one another and care for one another. So please tell others, and you're all invited to attend on the 15th of November,
8
that's
a.m.
8 a.m. at Cardio Care or Central Area Limi Hospital. Thank you for listening. We hope you join us again some other time. Bye.
Bye.